welcome to eCancer TV. Thank you very much for joining us.
Thank you. My pleasure.
Now you are past ESCO president. You're past everything in the United States.
Yes, I'm accumulating a lot of former this and former that kind of titles at this point.
Tell us what's happening in Chicago at the moment.
Well, as you know, I work at the University of Chicago. I've been there most of my professional career. I've had many roles there over the years. For the last several years, I've been the head of our Hematology Oncology division in the Department of Medicine. So, I supervise a group of about 60 faculty and about 200 staff, and we're the major clinical service in the hospital now. We actually operate 7 inpatient services, all for hematology and oncology patients, and then have a very busy outpatient clinical practice as well. And things are actually good for us. I mean, our hospital is making money. Our infrastructure on the campus has been substantially renewed in recent years. We've had 2 new research buildings have gone up. A new children's hospital opened a few years ago, and we're opening a new adult hospital next January. It's been interesting in Chicago in general, in the whole medical community in Chicago, because there have been many new hospitals that have just opened. So Northwestern has opened a new hospital. Rush University has opened a new hospital. We're opening a new hospital. It's a very competitive medical landscape. I actually wonder a little bit about the strategy of opening new inpatient facilities at a time when so much of medical care is moving increasingly outpatient.
Certainly oncology is.
Yes.
Almost totally.
And I think one of the struggles that we'll have, because we're going to have 80 inpatient beds in the new hospital, is how to keep those beds filled, because most of solid tumor oncology is all outpatient practice now. Even treatment of the hematological malignancies is more and more outpatient treatment. Many places have begun to do outpatient bone marrow transplants. We're contemplating doing that in our patient population. So, the patients who are in the hospital, the cancer patients who are in the hospital, are there for complications of therapy, symptom management, sometimes end-of-life care. But I think the way we're practicing cancer medicine now, many more patients are staying on treatment and doing well for longer periods of time. The therapies are less toxic. The supportive care medicines, even for the conventional chemotherapies, are better. So, patients have fewer side effects, and it really, the whole concept of how we practice oncology has really, I think, changed dramatically in the last decade or so.
We've had an interesting discussion here at the Eurocan platform meeting about how to afford this new care and how the economics stack up. And how do you think that's going to go?
Well, a big problem is the cost of the drugs, of course. And, at least in the U.S., it's a totally free market economy. So no one sets the price of new drugs, and no one regulates the price of new drugs. And at least up until now, Medicare and the insurance companies have been willing to reimburse the cost of new drugs as soon as they're FDA approved. So how to control that, is, I think, very problematic and difficult. And I think fundamentally, at least in the U.S., we need a different model, to support medical oncology practice. I mean, oncologists in the U.S. are essentially incentivized to buy and administer drugs, because that's how they make most of their money. And they don't receive very much compensation for all the cognitive work that's required to manage a cancer patient. It's difficult to get reimbursed for treatment planning, for survivorship care plans, for end-of-life care planning, for all the supportive care staffing needs that an oncology practice needs to have to successfully manage a patient throughout their illness. So until we can begin to shift the reimbursement model away from pushing drugs and toward providing services, I think it's going to be a very difficult model to change. Now, it may be different in the rest of the world where there are, more government controls on drug pricing and things of that sort. But, from what I heard discussed at the Eurocan platform, everyone in Europe is certainly concerned about the rising cost of care. And I think, that's putting a burden on us in the medical and scientific community to, number one, be sure we practice evidence-based medicine so that we're, only administering therapies that have a strong scientific foundation. And secondly, that we continue to do the research that is going to be necessary to better match these expensive drugs to the patient populations who are most likely to benefit from them. Probably the best case in point is bevacizumab and the other anti-angiogenic drugs, where we have no good biomarkers to identify the patients who are likely to benefit from those expensive and toxic therapies. And so many patients get those treatments, and some benefit, many do not benefit. We have no way of distinguishing one group from the other, and it contributes to driving up the cost of care.
So it's trial and error like the old days when you and I were young oncologists.
Yeah. Well, for those drugs,